the strength, the dynamometry, we don't have that because it's relative to your body weight, so you can standardize it relative to the body weight, and still it's hard to do. But I think the three of them we do. So we can get that to you. Yeah, I'll definitely share. Thank you. Should we go ahead and get started? I think it is recording. So thank you everyone for joining in. We're up. So I thought I'd do something a little different this time. We'll talk about exercise and lifestyle changes in patients with atrial fibrillation. So this is a really, really new body of evidence, right? We didn't think about this in the past, but this is really an up and coming new research that I wanted to share with you that has come out maybe in the past 5 to 10 years. Okay. So before we get into lifestyle changes and exercise, just wanted to kind of review what happens in atrial fibrillation. And if you guys, in a normal conduction system, we have these specialized conduction tissue in our heart where an impulse goes through, and that impulse, when it goes through the heart, it causes my heart to mechanically contract. So there is no mechanical contraction of the heart without this electrical stimulation or this impulse firing through the heart. And we move through this area called the SA node, and then from the SA node, it goes down to something called the AV node. And then from the AV node, it goes down to this bundle of His and then the Purkinje fibers, and it causes my heart to contract. So when my heart contracts, the top chambers, the atria, are the ones that contract first. And then the ventricles contract later on. So it's the atria contracting, and then the ventricles contracting. The atria contracting, and then the ventricles contracting. Usually when we think about our heart contracting, we think about the whole thing contracting at one time. And that's not really what happens. It's the atria contracting first, and then the ventricles contracting subsequently.
The pacemaker, where are the wires at?
So the pacemaker is dependent on where they put the pacemaker, right? Now, sometimes if you have a problem with your SA node, if the SA node is not working, then the pacemaker is put right in this area close to the SA node, right? And it will do the function of the SA node. Okay. In atrial fibrillation, it's not the SA node that's the problem. So usually they will disconnect this area, and then it will do the function of both. It's kind of put close to the AV node, and it's kind of, doing the function for both the atrium and the ventricles if needed. All right. So it really depends on what its function is. But usually close to the right atrium, close to this area right here is where they will put in the pacemaker. All right. Okay. So when you have normal conduction, you have this normal EKG. And I'm sure all of you guys have had your EKG taken at some point, where you'll have this nice P wave. This P wave is really telling me that my atria are contracting. When my atria are contracting, I get a nice looking P wave. Then you have this QRS complex telling me that my ventricles are contracting. And then you have this last wave called the T wave that tells you that the ventricles are relaxing. So in every heartbeat, we have the atria contracting, the P wave, the ventricles contracting, the QRS complex, and then the ventricles relaxing, the T wave. And then you give it a little time, and then the SA node fires again, and you have the atria contracting again, and then the ventricles contracting, and then the ventricles relaxing, and then the atria contracting, and then the ventricles contracting, and then the ventricles relaxing. And that happens in a normal cardiac cycle. So this SA node is called the pacemaker of the heart. And it's called the pacemaker of the heart because it makes the impulses that pace the heart. That's why it's called the pacemaker of the heart. It's making the electrical impulse that makes my heart contract. So that happens in a normal conduction system all the impulses that make my heart contract begin at the SA node. It's really beginning at the SA. All these impulses that make the heart contract really begin at the SA node. Now, in atrial fibrillation, what's happening is that this SA node has fallen asleep. It's fallen asleep. And you have multiple irritable sites in the atria that are now firing at a rate of 350 to 450 beats per minute at rest. Usually our atria fire 60 to 100 beats per minute at rest. Your normal heart rate, if my atria contracting 60 times, my ventricles contract 60 times. If my atria contracts 70 times, my ventricles contract 70 times. But in atrial fibrillation, the atria of all of these impulses in the atria are firing 350 to 450 times per minute. And because you have so many impulses firing so fast, the atria just begin to quiver. They don't contract, they just quiver. And that's what we call fibrillation. Fibrillation is defined by quivering of the chambers because of lack of inadequate electrical stimulation. We have inadequate electrical stimulation that makes the atria quiver instead of contract. So that's really what. So because we have all these foci, all these impulses firing all over the atria, we don't really have a P wave. Because the P wave is signifying that the atria are contracting. But in atrial fibrillation, the atria are not contracting. They're just quivering. And because they're quivering, you have these squiggly lines that we call fibrillatory waves. Fibrillatory waves. It's because of all these impulses firing. And okay, so how do we manage atrial fibrillation? Now, when somebody is in atrial fibrillation, just because the atria are firing 350 times a minute, that would technically mean that the ventricle should fire 350 times per minute. But that doesn't happen, right? If my atria are firing 350 times a minute, these impulses go into the ventricles, and my ventricle should fire 350 times a minute. But that doesn't happen. And it doesn't happen because of this guy. This guy called the AV node. So this impulse fires, it goes to the AV node, and the AV node says, nope, I'm not going to let you down. This guy fires, sorry. This guy fires again, it goes to the AV node, and the AV node says, no, I'm not going to let you down. And it only allows some of the impulses to go down, and it keeps my heart rate between 60 and 100 beats per minute. And people walk the streets of Sacramento, even though their atria are firing 350 times per minute, they're walking the streets of Sacramento because the AV node is doing a good job. But if the AV node is not doing a good job, then more of these impulses go into the ventricles and somebody's heart rate goes really high. Their heart rate can be in the 120s, 130s, 150s. And that's what we call uncontrolled atrial fibrillation, sometimes known as atrial fibrillation with rapid ventricular rate, right? So the heart is beating really fast. Now, when somebody's heart beats really fast, we call that uncontrolled atrial fibrillation. Now, when somebody has, so if you have a patient with atrial fibrillation, one of the first things we look at before you exercise is we look at your resting heart rate. We look at your resting ventricular rate. And we would like to see your resting heart rate under 100 beats per minute, usually between 60 and 100. If it's between 60 and 100, it is telling me that the AV node is doing a good job and your heart rate is doing well, even though your atria are quivering. Now, if your heart rate is greater than 100 beats per minute at rest, we now call that uncontrolled atrial fibrillation. And if somebody has uncontrolled atrial fibrillation, when the heart is beating so fast, there's not much time to fill the ventricles with blood. So less blood comes out of my heart, and you are less likely to be able to tolerate exercise. Now, in addition to that, if my atria are quivering, my atria are not contracting forcefully, and so we lose something called the atrial kick. The atrial kick is a concept that signifies that about 30% of the blood that's coming out of my heart is because my atria contract. When my atria contract, that accounts for about 30% of the blood coming out of my heart every minute. When my atria are quivering, then you've already lost 30% of the blood that's getting out of my heart. And so your ability to tolerate exercise is less. And that's why they put you on medications to control the rate. You can be on a beta blocker. You could be on a calcium channel blocker. You could be in an antiarrhythmic to control the rate. Okay, so that's the first concept. So the first thing we try to do in the management of atrial fibrillation is to control the rate, and we do that with beta blockers. The second thing is we try to get the SA node to refire. We try to get the SA node to kick back on. We try to stop all these ectopic, all these irritable sites from firing. We try to get the SA node to re-jolt itself. And we can do that by doing something called a cardioversion, right? They can do an electrical cardioversion. They can do a chemical cardioversion with medications like amiodarone, right? So they can use medications, they can use chemicals, they can use electricity to shock the heart out of the rhythm back into a normal rhythm. They can also do something called an ablation procedure, right? An ablation procedure. So in an ablation procedure, they burn out the area that's giving trouble. They burn out the area that's giving trouble. Now, look at this heart. It's got foci everywhere. Do you think they're going to burn out the whole atria? That wouldn't be smart. They're going to burn out the whole atria, right? So what they do is they actually burn out oftentimes the AV node. They burn out this area, and then they use a pacemaker to pace the atria and the ventricles. So usually they'll do an ablation and they'll put in a pacemaker after that to allow the atria and the ventricles to work independently without the AV node. So that's often what they do. Okay. The third major management consideration for atrial fibrillation is anticoagulation and blood thinners, the use of blood thinners. So, you know, what they thought of in the past is when people have atrial fibrillations, right? The atria are just quivering. They're not contracting. So if my atria, the top chambers of my heart are just quivering, blood sits in the atria. It collects in the atria because they're not contracting. So when blood just sits in the atria, blood can collect. And when it sits there for a long time, you can get blood clots. Blood clots start to form when blood is just sitting. Now, at any unpredictable moment, if my atria contract, that blood clot gets dislodged. It moves through my blood vessels. It can go to my brain, and I could have a stroke. And that's how people have strokes when they have atrial fibrillation. Okay? So that's what we knew from the past. But now our understanding of stroke in atrial fibrillation has dramatically changed. How has it changed? So you can have somebody, you can have, let's say this, 55-year-old individual, no diabetes, no hypertension, normal looking heart, and they can be in atrial fibrillation for 24 hours in the day. And that individual's risk for having a stroke is the same as you and me in the general population. So they can be in atrial fibrillation the whole day, 50 years old, normal looking heart, no diabetes, no hypertension, and their risk for having a stroke is the same as you and me in the general population. You have another individual who's 80 years old. That individual has diabetes, hypertension, problems with their ventricles, and that individual is in atrial fibrillation for only 20 minutes in the day. And that person's risk of having a stroke is 8 to 10 times higher than the general population. So now we've come to realize that just because atrial fibrillation and stroke coexist, atrial fibrillation is not always causative of a stroke. Just because you have atrial fibrillation is not always causative of a stroke. What causes a stroke are other factors like having heart failure and having diabetes and having hypertension. When you have all these other things, that's what really increases your likelihood for a stroke. So now what the physicians use to determine how much of anticoagulation and whether to give somebody anticoagulation, we use a risk score called the CHADS-VASc risk score. CHADS-VASc risk score. That means if you have heart failure, you get 1 point. If you have hypertension, you get 1 point. If you're more than 75 years, you get 2 points. If you're between 65 and 74, you get 1 point. If you have diabetes, you have 1. You add up all the points, you get a score. And based on your score, they now decide how much of medications to give you. It's the CHADS-VASc risk score, right? Because giving people too much of anticoagulation and making your blood really thin could sometimes be problematic in older individuals. Because if you have very thin blood and you fall and you bang your head and you have a bleed, that's a problem. So we gotta manage that very carefully in terms of how much of anticoagulation we can give people. Oh, this is the current procedures. Yeah, this is currently what we use.
I was 71 years old and I was in AFib 12 hours, really high. And I had just had brain surgery, so they sent me home with no anticoagulation.
Yeah.
I had no diabetes. I did have hypertension.
Yeah.
And
So
I had a serious stroke.
Yeah, so it's patient dependent. Everyone's different. So sometimes if your risk of having an embolic stroke, if you've already had a hemorrhagic stroke, so there's 2 types of strokes. Embolic is a blood clot in the brain. Hemorrhagic is the bleed in the brain, right? You give someone too much anticoagulation and you keep their blood really thin and their blood pressures are really high, you could bleed. So we've got to be very careful with how much of anticoagulation they give people as well. So it's very patient dependent. So my point I'm trying to make is just because you have atrial fibrillation does not mean you have to be on lifetime anticoagulation. It's patient dependent, it's risk dependent, right? Every time people feel, oh, I've got atrial fibrillation, I have to be on all these. It's a discussion with the doctor. Most cases, they're going to put you on anticoagulants, but in some special instances, based on your risk, based on other factors, they may decide what is best for you. Questions on that? So we have discussed the three. You can come back to it. You can come back. Yeah. So, what's that? Female. Female gives you 1 additional point. Yeah. Because of the hormone and, loss of estrogen and all that, estrogen imbalances, they give you an additional point for that. Yeah. Regardless of whether it's just because there's hormone imbalances there, it changes the viscosity of your blood. And that's why they add in a point there. Okay.
If you have atrial fibrillation, you have the rest of your life?
That's a good question. So the question is, once you have atrial fibrillation, do you have atrial fibrillation for the rest of your life? So I'm going to answer that question before I get out today, based on the evidence. Okay, so we'll talk about that. All right, that's a really good question. All right. So far, we've talked about 3 major pillars of managing patients who have atrial fibrillation. Pillar number 1, managing the rate, trying to keep the rate under 100 beats per minute. Number 2, managing the rhythm. If you're not in a normal rhythm and you're in atrial fibrillation, we can do things to put you in a normal rhythm. Pillar number 3, anticoagulation to reduce your risk for stroke. So traditionally, we have always followed 3, and we continue to follow 3 pillars in the management of atrial fibrillation. But now, very recently, in the past 10 years or less, we have new evidence on the importance of lifestyle changes. And the lifestyle changes is based out of a compelling body of evidence that now helps us understand the mechanistic contributors that cause atrial fibrillation. How do we get all these ectopic foci in the atria? What causes that? Because once we understand what causes all these irritable sites, we can intervene based on the causative mechanism for these ectopic foci, these irritable sites. And now we know that when people have diabetes and they don't manage their blood glucose, when people have obesity, a BMI greater than 30, when people don't manage their hypertension, when people have obstructive sleep apnea, stopping breathing when you sleeping at night, all of these factors collectively, they distort the atrial geometry. They distort the atria. They enlarge and dilate the atria. And when you change the atrial geometry, you cause these ectopic foci. They cause the atria to become electrically irritable. That's the causative mechanism for how the atria becomes irritable. So it's really things that are in our control. If we can manage body weight, if we can manage glucose levels, if we can get people to sleep better, if we can get people to manage their blood pressure, there's an opportunity to reverse atrial fibrillation. There's an opportunity to reverse atrial fibrillation. So that brings me to this really important study that set the stage for further studies. And this was a study that was done by a physician and his team called Prashantan Sanders out of the University of Adelaide in Adelaide, Australia. Now, in Australia, they have a nationalized healthcare system, right? So if you have atrial fibrillation in the United States and you want an ablation, you get an ablation tomorrow. That's the way we work. If you need an ablation, you get an ablation in a few days. If you need an ablation in Adelaide, Australia, you're put on a waiting list. And you have to be on that waiting list for months. You're not going to get an ablation tomorrow. That's just how it works, right? So these people, they took individuals who had atrial fibrillation and were on a waiting list for an ablation. And they found people that were obese, BMIs greater than 30. And they randomized these patients into one group that was involved in a physician-driven risk factor modification program, comprehensive risk factor modification program. The other group got standard care. They were just in the AFib clinic. They didn't get anything else but what they did, standard care. They measured the AFib, they gave them a medication, and they just, did some education, and that was it. So one group got comprehensive, they managed their body weight, they gave them exercise, they gave them diet consultation, it was a comprehensive program. And in a matter of 15 months, okay, so they had two groups. In a matter of 15 months, for those people that got the intervention, that got the risk factor modification program, they were able to get the BMI down 6 points, 6-point reduction in BMI. In 15 months, that's huge. They were found that in 15 months of a comprehensive program, the waist circumference came down. People were able to get off their medications for hypertension and diabetes. And the most important thing that they found is that they measured something called the University of Toronto symptom score, which measures the burden of atrial fibrillation. How much of burden does atrial fibrillation cause on your symptomatology? You can measure people's symptomatology, and that helps us understand the burden of atrial fibrillation. And they found significant reductions in the burden of atrial fibrillation using the University of Toronto symptom score. In addition to that, what they found is that they did a cardiac MRI. They did a cardiac MRI on these patients at baseline, where they looked at the atria at baseline. And then they re-looked at the atria after the 15 months. So they did another cardiac MRI, and they looked at the atria after 15 months. And after 15 months, what they found is that after 15 months, in those that got the intervention, the atria shrank. The electrical properties of the atria reversed. There was less fibrosis and inflammation in the atria after 15 months of lifestyle change. This whole atria looked completely different, significantly different from those that didn't participate in the program after 15 months.
They were still in atrial fib.
And the atrial fibrillation had gone. It went away. They didn't have the atrial fibrillation. So that gave us the impetus to say that doing these lifestyle changes is changing the mechanistic contributors the causative contributors that are causing atrial fibrillation in the first place. How cool is that? You know, when you talk to most doctors, if you ask them, oh, you have atrial fibrillation, they're going to say, oh, you need a medication. You need an ablation. You have atrial fibrillation for the rest of your life. But the fact of the matter is really based on this compelling body of evidence. If you lose body weight, if you manage these contributors, your atrial fibrillation could actually disappear. So then they did another study called the Legacy Trial. It was also done by Prashant Sanders and his team and other colleagues, right? And they looked at people that lost greater than 10% body weight, which is the guidelines of the American Heart Association. The American Heart Association would like us to lose at least 10% body weight. Looking at 10% reduction body weight, 3 to 9% reduction body weight, or less than 3% body weight. How many people over a course of 6 months or more lost more than 10% body weight, lost 3 to 9% body weight, or lost less than 3% body weight? And they found a stepwise reduction in the amount of atrial fibrillation you had at 3-year follow-up. So after 3-year follow-up, or maybe was it 5-year, 3 or 5-year follow-up, they found that those people who lost more than 10% body weight had the least amount of atrial fibrillation compared to people that lost 3 to 9% body weight, compared to people that lost less than 3% body weight, which actually had the most atrial fibrillation at 3-year follow-up. Now, let's think about this, right? 10% reduction in body weight. So if you have an individual who's 250 pounds, and you get that individual to 225 pounds, you can reverse the atrial fibrillation in 3 years. That is pretty compelling. That's really compelling evidence. That's not a great reduction in body weight. It's a modest decrease in body weight. And if you can get somebody from 250 to 225, it could be pretty meaningful, right? So really, the point of what I'm trying to make in today's presentation is really, we often think about atrial fibrillation as a lifetime issue. And based on this new body of evidence, there is really reason to understand that a lot of time atrial fibrillation is caused by risk factors. Just like you have heart disease, and your heart disease is caused by, high cholesterol and diabetes and stress and smoking and anxiety, and all of these cause heart disease. Similar to heart disease, atrial fibrillation is caused by risk factors. And these risk factors contribute to the development of atrial fibrillation. And participating in a program like this one at the Cardiovascular Center is really setting you up for success. It's setting people up to manage these risk factors, to delay or reduce the likelihood of atrial fibrillation. And that's all I had for today. Any questions, Linda?
People that go into AFib, but basically are already maximizing these lifestyle choices.
Well, everybody is different. Everybody is different, right? It just doesn't mean that if you, participate, it's not always the case, but the likelihood is higher, or your likelihood for worsening symptomatology using the AFib burden score is more controlled when you are participating in lifestyle modification factor. It may not completely reverse the age, but it reduces the number of episodes of atrial fibrillation a day, or the amount of atrial fibrillation people may have. So it's not always, that you may completely reverse atrial, but the likelihood is high. Other questions?
What do you know about
Paroxysmal?
no, probably atrial fib is pretty common, especially in people.
Yeah. Age is definitely a factor. That's why, as you saw in the Chad-Baxter risk score, greater than 75, your likelihood of getting atrial fibrillation as we age dramatically increases. We're all at risk, right? But that doesn't mean that, you will have to be in atrial fibrillation for the rest of your life. It doesn't mean that. I think there are things that are within our control that could help with medications. Sometimes exercise is the best medicine, right? Really, when you think about exercise and lifestyle changes, that could actually sometimes do better than the medications that physicians could offer you.
Some functions when you exercise. For example, if you are getting your heart rate considerably higher.
Yeah. That's a really good question. That's a really good. So let's talk about exercise considerations in people with atrial fibrillation. And actually I wrote a paper on this, which is getting published actually. It's already accepted. And I can share with you that paper in a follow-up once it's officially in print, but it's already accepted to be scheduled to be in the journal in a couple of months, or maybe by September. But the first important consideration is really to look at the resting heart rate of the individual, as we already talked about, right? The resting heart rate really helps us understand if you're going to be able to tolerate the exercise better. And if somebody is in atrial fibrillation and their heart rates at rest are in an uncontrolled region where it's greater than 100, 150, etc., then you're less likely to tolerate the exercise. So getting it more controlled at start is the first important consideration. But closer to 100 would be ideal. Less than 100 would be ideal. If you cannot get it all the way under 100, closer to 100 would be better. Like if your heart rate's really high at rest, then we should really kind of think about that. And that's really related to the atrial kick that we talked about. Second consideration. Really, what we need to be looking for is your blood pressure response and looking for signs and symptoms of the amount of blood coming out of your heart, which is the cardiac output. So symptoms like dizziness, lightheadedness, fatigue, being overly tired, those are signs and symptoms of reduced cardiac output. And the best way to understand if the cardiac output is reduced is to take your blood pressure, right? We'll talk about this in multiple other talks. The reason why we take blood pressure during exercise is to help us understand how much of blood is coming out of my heart during exercise. And usually we like to see the blood pressure increasing with exercise intensity. But if the blood pressure is going down or the opposite way, that would not be a good sign. So we want to make sure that your blood pressure is being maintained with the intensity of the exercise that you're participating in. Now, there is a body of evidence talking about high-intensity exercise. Now, I'm not saying high-intensity exercise is for everybody, but there is evidence that even shows that high-intensity exercise could be beneficial to a certain degree. We have something called the U curve, right? The U curve. And the U curve suggests that if you have little to no exercise, your risk and prevalence of atrial fibrillation is really high. If you do too much of exercise, run 50 miles a week, you're a triathlete, and you do too much of exercise, we see in people that do too much of exercise, higher degrees of atrial fibrillation. So atrial fibrillation is high in those that don't do any exercise and those that do too much of exercise. And the sweet spot is in between where we see the lowest level of atrial fibrillation.
When you're listening to, do you get a difference in the love job?
Yes. When somebody has atrial fibrillation, when you feel their pulse, it'll feel very irregular. It'll feel we call it irregularly irregular. It's just completely irregular. We say it's irregularly irregular, right? You can have your pulse regularly irregular. So like every fourth beat could be regularly irregular. But when you have atrial fibrillation, it's completely irregular. It is irregularly irregular. So when you feel somebody's pulse, it's just completely irregular. That's how we identify atrial fibrillation. Same thing when you listen to the heart. It just kind of, the lub-dub is not going to come in regular intervals of time. It will just be very irregular. Again, because what happens in atrial fibrillation is you have all these impulses firing, they go down to the ventricle, and the ventricle contracts. And then another one comes and the ventricle contracts. And then the ventricle contracts. And then two contract. And then, so there's so many coming down that it contracts in irregular intervals of time. And that's why, we feel it pretty irregular. Any other questions? All right. If there's something you guys want me to talk about in terms of exercise for the next one, let me know. What would you like to listen to? What would be of interest to you? Anyone on Zoom?
Hello, can you hear me?
Yes, I can. Thanks for chiming in.
Uh-huh. My name is Grace. The types of exercises that we do with Linda, are you familiar with them?
Somewhat, yeah.
Are they good? Well, I'm sure they're good. But should we be, is weight bearing maybe better, or weights, or a little bit of everything?
That's a great question. It's a loaded question. It's a question that's hard to answer in a few sentences. But I think what the essence of your question is really relating to the intensity of the exercise.
Right.
And how do we dose the intensity to ensure that we're in the sweet spot of it being safe and effective? Right? I think that's really what you're aiming at. Like, how do we understand the appropriate intensity of the exercise to really make sure that, we're not underdosing? And that's a big problem. I mean, we as clinicians, we struggle with that all the time, right? I tell my students this all the time. A lot of times we underdose the exercise. Are we underdosing the exercise? And it's so individually dependent. Like, everybody is so different. You can't have this prescriptive, this is, you have 5 pounds or 3 pounds or 15 reps or 10 repetitions. But we use a few ways to gauge the intensity. And maybe that would be a really good session, upcoming session, to talk about how do we think as clinicians about dosing the intensity of exercise in different patients and clients. And I could do that. So thanks for that suggestion.
Thank you.
I think it was a comprehensive program. They did exercise, they did aerobic exercise, but I don't know at the top of my head the number of minutes of exercise. I don't have that at the top of my head, sorry. Great suggestion.
I was reading a paper about natural movement being a better benefit than structured exercise.
Yeah.
Think of that.
Yeah, actually, so, I never believed in yoga. And now I've been YouTubing all these yoga videos because I don't have a very good back. And I should be having a good back. I'm a PT for crying out loud. But my back is not great. And so I have been actually doing quite a bit of yoga, and it's quite impressive, actually. Tai Chi and yoga and some of the stretches. And so, I think,
And the paper was suggesting walking, gardening,
oh,
those
okay.
kind of
Yeah, I think
natural-
the best. I think walking is the best exercise. If you can keep yourself just moving,
Yes.
it's all about just keeping yourself moving. All right. So I'll think of something related to intensity or something else for the next session. But thank you so much for joining in. I'll try to keep you entertained. Have a good one. Have a great weekend. Thank you so much. All right, Ivan, all yours.